Well, thank you for that really interesting presentation, Cindy, and your team. Absolutely wonderful. I'm not going to officially thank you yet. Our president, Jim Parks, will thank you shortly. But I wonder at this point if I could ask Cindy and the questions and answer team, that's Dr. Katie Burt and Dr. Rudy Bindlish, to come on. Thank you. I see you all there. Cindy, I thought perhaps we'd start off a few questions specifically about your research, and then we'll open it up to general questions which have come in. We have approximately 10 questions in all, so hopefully we can keep on time. So, Katie, did you get a chance to ask your question before we all disappeared?
No, I didn't. Although I think we were thinking along the same lines because it's not that dissimilar from your question. But
Right,
Cindy, if I have a patient with low pressure glaucoma, particularly, who's getting worse, is it worth trying one of these? Not prescribing it myself, perhaps, but speaking to their family doctor and seeing whether one of this class could be attempted?
Yeah, well, Katie, I was going to do the tricky thing of asking you, Graham, and Raj, but my short answer is, I hope people heard my answer. I would still be, the same holds true, whether the patient has high pressure or low pressure, that we have to be cautious about using drugs off target or off label for something they weren't approved. But that being said, I don't know throughout your training, I've certainly at conferences have had discussion, especially with some of my American colleagues, who, when they have those patients who are progressing and they just don't know what else to do, that's when they start saying, why don't we try ginkgo biloba? Why don't we try this? So even though it's off-label and it's not what it's indicated for, I think with no other evidence than discussing things at a meeting with another colleague, I see people sometimes go ahead and try things. And I think the key point there is the communication with the patient. Patient has to be informed at a level that they can understand what's going on, what are the risks of treatment, what are the risks of non-treatment, what are the benefits. So it was with caution that I would maybe consider this in a patient who is progressing despite low pressures, but still being very concerned that if it's off-label, there are risks.
Yeah, I'd be nervous myself. The adage, first do no harm, coming strongly to mind, prescribing things that I don't routinely do. Thanks.
So Katie, can I just say, you've given talks on complementary medicine before. Would you consider some of those, maybe?
The evidence for all of the complementary sort of non-medical interventions is pretty weak. Things that are relatively or almost completely harmless, such as recommending more exercise and a good, healthy, varied diet, I have no problem with that. But anything that comes with significant risk of doing harm, such as THC, CBD oil, some of the more esoteric things, even ginkgo, which is quoted fairly frequently as being useful, can in some people precipitate significant problems with blood clotting, or rather not blood clotting. So yeah, I'm cautious, and as you said, we'll talk about it with the patient.
Yeah, so just a couple of things. So first of all, I agree with Katie. I'm a little worried about recommending these medications to patients. I did have in my career one time where I had a bad incident of a patient where I did recommend ginkgo, and it wasn't a very good outcome for the patient. So I do recommend caution. Just a quick note, I would very much like to thank Santen for sponsoring this meeting. They were very helpful in getting this going. So I really want to thank, just point out to them. So Cindy, what kind of studies are required to study these types of medications to see their benefit in glaucoma?
Yes, my answer is going to, my answer is going to, I don't know why we're getting feedback now. Are you guys hearing me okay? So something that Jacqueline said is that when we move research forward, we first of all want to rely upon a strong premise of why it makes sense. So if indeed the type of study we're doing now shows the possible association, the type of research that would be needed in the future would be something called a prospective multi-center randomized clinical trial. So it would be prospectively, before we know the answer, we would be enrolling patients. We'd be putting some of those patients on these drugs. Some of these patients would not take these drugs, and then we would compare outcomes. And interesting again with the panel that we have here, historically glaucoma trials have used the outcome of visual fields, but I'm wondering now if we're specifically looking at nerve tissue outcomes, if we would resort to our OCTs, our diagnostic imaging tools now, where we actually measure the retinal nerve fiber layer. And maybe, just maybe, if structural damage precedes functional damage, we may be able to do these studies in a time period that historically will be shorter than the visual fields. We've known from other studies that it takes at least 5 years to really get an idea about if a visual field is changing because of the type of test. So my short answer is it would be a prospective multi-center clinical trial and maybe using diagnostic nerve imaging as the outcome measure.
Thanks very much. Are there any other questions, Katie or Raj, before we go into some general questions which were sent in?
I'm just curious, when do you think you'll have results from the study, Cindy? What's your timeline?
It's going along very well. We are on the tight timeline because, believe it or not, we actually respect the parameters that the Glaucoma Research Society puts out. So I know the team has just last week, met with the ISIS team. What happens is an ICES, and by ISIS I mean ICES, not the other ISIS. What this means is that the team actually really defines the question, because an ICES study is actually very expensive. So what they managed to do last week was to narrow it down, and then once we actually have the actual question we want to ask and the data we want to extract, it moves along quite quickly. So we're hoping by next spring, maybe late summer. What do you think, team? Do you think, Jake, what do you think? 6 months? Do you think we'll have our first set?
That would be very doable, yes.
Yeah, very doable. That's the nice thing about doing it. Once you've really got a nice question and you've got the ICES people on board, it tends to go along without too many glitches.
Well, thank you very much. That's very, very interesting. So, Cindy, perhaps we'll direct the question at you, but please don't feel obliged. You don't have to only answer, and we'll ask Katie and Raj. Raj is very used to answering questions. He answers them for our newsletter in a remarkably effective way. Much appreciated as well, Raj. Thank you. So, Cindy, we have a question here from someone called Merle, and Merle she makes a statement, then asks a question, namely that given the close connection between glaucoma and severe dry eyes, why is so little attention paid to the dry-eyed situation? I'm not sure she's correct in saying we don't pay attention, but do you have any comments about that?
It is something that I think we've all recognized and struggled with, because if we look at who gets glaucoma, obviously it tends to be more of an age-related diseases, and we know dry eye and ocular surface disease, its prevalence goes up to close to 80–90%. So almost every patient has an element of dry eye at the time they're diagnosed with glaucoma. And you know, Graham, I don't know if it's because we as ophthalmologists focus so much upon one aspect, and of course glaucoma is the frightening aspect that can permanently impair your vision, that we sometimes lose sight of the fact that we should be co-treating the dry eye. So there are very effective treatments now available for dry eye. Now, the fact that there's many treatments suggests there's not one perfect treatment for everything. I think it's very multifactorial. I don't know, and I'd love to hear what Katie and Raj says. Do you think because it's a frustrating multifactorial disease? Is it because it's such a chronic disease that patients just fall off the rails? Do you think it's because glaucoma patients actually do have more severe dry eye? What are your thoughts? So, Katie, what are your thoughts?
Yeah, I would say that as you originally alluded to, the vast majority of my patients have some degree of dry eye. And whether it's, I don't think it's because of the glaucoma, but it may well be worsened by the glaucoma treatment. So the drops that we put people on, because they're mostly the preservative, preservative is there to kill bacteria, and so it has effect on the living cells of the eye, and so it worsens the ocular surface, and that's dry eye is part of the ocular surface disease spectrum. There are things we can do, including there's a couple of preservative-free glaucoma medications, as you know, and they're often good choices for people with surface disease issues. Lubricating the eye with a preservative-free lubricant, even though more expensive, avoids another dose of preservative on an eye that's already having to take preservatives for their glaucoma management. And then, as you say, there are other things you can do with blocking the tear duct into the lid, increasing production of tears using various medications. Personally, once it gets to that stage, I usually involve a colleague with external disease specialty or someone who works on lids to help with it. But I doubt I ignore it, because almost every patient, the glaucoma doesn't cause as much symptoms as the dry eye does.
And Katie, I have to say that you published that PISO study that actually showed that the load of preservative can actually affect the outcome of glaucoma surgery. So I know you're a strong believer in what you just said.
Yeah, ever since that, I've been convinced.
So, Katie, that nicely answered Dawn's question, because Dawn asked specifically about whether you, not you personally, but whether ophthalmologists should be prescribing only preservative-free drops. I wonder if you'd like to.
I would if I could.
Sorry, you would?
Yeah, if we have one preservative-free combination drop, co-sold with that preservative, which is covered by the ODB. We have one drop which is approved for use, but is not covered by the ODB, which is a preservative-free Xalatan or latanoprost called Monoprost. And for some people, they're willing to pay to take the preservative-free drop that the government won't pay for them when they're over 65. And sometimes it really, to them, it's hugely worth it. Their comfort level is so much better when they get off the last drop of preservative. And you can also get a couple of other drops made preservative-free at what's called a compounding pharmacy, who not a regular commercial pharmacy, but it's made as a one-off. And that's also very expensive and also much less easy to get. You have to be in touch with only one or two pharmacists in the city. And I don't know about how easy it is if you're in a smaller town somewhere else. So the options aren't as widely available as I'd like. Given a free hand, I would prescribe preservative-free the vast majority of the time.
Thank you. So Raj, we have a question from Vicky who really extends the same question, but this time to the eyelids, asking about blepharitis and inflamed lids. It's really the same question, I think, but do you have any further comments to make about dealing with inflamed, sore, red eyelids, colored eyelids, all sorts of...
Again, ocular surface disease, blepharitis, meibomitis are very common in glaucoma patients. And again, chicken and egg scenario, does it come just from age and dry eye, or does the glaucoma medications contribute to it? I do strongly recommend patients to do a few steps every day. One is a hot towel on the eye every day for 5 minutes. I do recommend they do something called lid scrubs. So they clean the base of the eyelashes with a mild cleanser. There are some commercially available ones, Blephagel, Calmo. Some people, I just recommend straightforward Johnson & Johnson baby shampoo. So those are two things that I definitely recommend. Having done some anterior segment cornea fellowship, low-dose doxycycline, which is a tetracycline medication, can be very helpful in treating lid disease. So if I have some very sort of uncomfortable patients with very active lid disease, I will prescribe low-dose doxycycline for 2 to 3 months to see if that will help settle the blepharitis. There are some other treatments as well focused at the meibomian glands, such as LipiFlow. I don't have a lot of experience with them. I don't openly advocate those treatments because people have to venture to a private clinic and pay out of pocket. And I really wonder how successful they are. But Some majority of people, if they can persist with what I recommend, I do find it helps their condition.
And if I can just add, Raj, those are great comments that I think every glaucoma patient should be doing. And one caution is another medication that's sometimes prescribed for eye discomfort and eyelid discomfort are steroid-based medications. So they can come in eye drops or as creams. And glaucoma patients have to be very cautious when you take any medication that's considered a steroid. Yes, it'll make the eyelids feel better and the eyes be less red. But if you use them chronically, it can actually make your pressure in your eye go up quite high in some patients. So I think what Dr. Binlish just mentioned is by far the safer approach. And if you do it religiously, I think it's just a good plan. And there's really nothing harmful about anything you've suggested to treat the ocular surface.
Yeah, it is definitely a major problem, and there's no doubt that we cause some difficulties for the patients and for our cornea external disease colleagues who constantly are receiving these patients from us. And every now and again, they tell us to stop the drops completely, and to consider alternatives. And there are alternatives. They also come with risks and benefits. There's lasers that you've written about, there's surgeries. But we do create a lot of problems with our eye drops. So I think we could spend all evening talking about this. Perhaps I could move on slightly. Still another question by Vicky. She says that she's had a little bit of trouble getting to the ophthalmologist with regard to her red eyes. The ophthalmologist didn't have their office open and requested photographs of the eyes. So it brings up the whole issue of COVID and access to eye care, which is a little bit beyond the scope of this meeting. But I wondered if you could tell us in London whether everybody is back at work. Cindy, are people being asked not to attend unless it's absolutely essential? Where are we with COVID? Can patients come in with red eyes to see you? If not, how do you deal with such situations? Thank you.
Well, that's a great question. For 3 months, the Ivy Institute of Ophthalmology was shut down. So we had a huge backlog of patients that weren't being seen. We opened up in a staged way where we were assigned days and clinic space just to keep our patients properly spaced. When I see patients, I'm all wrapped up and we have plexiglass shields. So the answer is we've ramped up, and we've ramped up pretty significantly. But what's happened is in Ontario, some of the optometrists have kind of gone on a partial strike. So we're having a lot of patients coming in through our urgent care and then being sent off to our eye care urgent, what we call clinic. And probably the busiest week I've ever had in my whole career was when I was on call about 2-3 weeks ago. It was just inundated with patients having sore red eyes because they either hadn't been seen during the 3-month shutdown or their optometry offices aren't open. So one thing they've done in London, they've actually named a doctor as what's called the chief information officer to look more closely at telehealth and telemedicine, and then teleglaucoma is being explored by the Canadian Glaucoma Society. Because I must admit, I don't know what your opinion is, Graham, but doing ophthalmology in a telehealth way is a little bit challenging, since so much of what we see is partly the picture, but again, the eyeball's attached to the whole patient. So I think we're moving in the direction of artificial intelligence, taking pictures of parts of the eye and sending them in. But it truly is, I think we're on the cusp. I think what COVID has done is made us think about what are different ways that we can utilize to take care of our patients, and maybe access to care will be made more possible for people who can't get into a urban center. So I think we're looking at change over the next 5 to 10 years and how we do things.
Katie, Raj, any comments?
Yeah, I think perhaps we need to recognize that telehealth between a family physician and a patient, a lot can be done over a phone or with a computer link such as we're using tonight. But when we talk about telehealth in glaucoma, we're really talking about a distant ophthalmology office with all the equipment to do visual fields and OCT scans, and check pressures, being linked to an interpreting office at another center. So kind of hub and spoke. But it's not something that can be done by a patient in their own home. I did a few phone calls with people, but I can't do my job over a computer link at the moment with someone at home. And so if people can't come in, I can't assess them properly. I hope that the technology will allow us to do some of these remote visits for underserviced areas, remote communities, flying communities, what have you. But for most of my patients who live in the Greater Toronto area, they're going to have to come and see me, just like my cat is.
Raj, any further comments? Any experiences?
To be honest with you, I'm not a big fan of tele or virtual ophthalmology care at present. Being a more community-based ophthalmologist, I had the luxury of being able to keep my office open to some degree. Obviously with full protection and screening, but I wasn't shut down by a hospital. Unfortunately, some our other colleagues here, their offices are in a educational institution, and so they're under a different mandate. But I have to admit, there are many different causes of a red eye, and it's not necessarily just an allergy to the glaucoma drops. I've seen people with red eyes who end up having very bad infections, or they could have inflammation in their eye. And the critical point is they need a slit lamp exam, and that slit lamp can't be done virtually over a computer. So it is a difficult situation, and I think a triage over the phone could really tell us, do we have to see you that day or the next day, or perhaps then we can say, okay, let's give it a few days with these recommendations, but then a definite level of follow-up. And I think that's important.
Thank you very much indeed. We only have one last question. Time is going by, and as long as Katie isn't attacked and eaten by that leopard behind her, it would be great. So this is an interesting question, perhaps aimed at you, Katie, because of some of the work you've done. And the question goes like this: because of poor vision and dexterity, sometimes I find it takes 2 or 3 tries to get drops to land in my eye. I searched eye drop dispenser and eye drop guide and found on Amazon many plastic devices that fit over your eye and try to center the bottle over your eye. Are these products safe? Are they effective? Are they recommended? And is any particular type better than others? So perhaps, Katie, if you could take a question and then we'll hear from the others.
I think you were referring in your introduction there to a study I did quite some time ago, looking at one particular type of eye drop guide. And we asked people to use it and to rate it and tell us whether they liked it or not. And in fact, the majority, a lot of people liked it, but the slightly larger number didn't like it and didn't feel it helped and didn't want to go on using it, which was disappointing. I haven't got any sort of comparative evidence of brand A versus B versus C. So I think I would say, like I do with my artificial tear eye drops, pick one, start with the cheapest. When you find one you like, stick with it. There's no doubt that putting the drops in can be a definite technical challenge. And unfortunately, sometimes the pharmacists don't recognize that patients can waste a drop or two when they're putting them in, and run out earlier than if they were doling out a pill where you take one pill and one pill only. And so if patients run dry early, they need to tell their pharmacist to get a refill. Yes, I ran out a week early, I still need my drops.
I had an interesting experience a few days ago. One of my patients hadn't put his eye drops in when he came in to see me. And as usual, I got very irate when he honestly told me that. And I said, well, why didn't you put the drop in? He said, well, my wife didn't have time to put it in. So it reminded me of the fact that you actually can train most people to put in their own eye drops correctly. You really can. And I think patients should be trained, and we as ophthalmologists don't do a very good job. We need to show patients how to put the drops in. We need to make sure they know how to do it. And studies have shown that if we do that, the outcome is actually very good. You can train people to put their own drops in. And to expect others, like wives or children or friends or nurses, to put the drops in is not ideal. Now, obviously, there's some patients who have to have the drops put in. If someone's in a nursing home who doesn't have the dexterity. But most of the time, you can train most people to put drops in correctly. I don't feel about that, Cindy or Raj. Have you had similar experiences at all?
But I agree.
Yeah. Go ahead, Cindy.
Oh, no, go ahead, Raj. Go ahead.
No, I was just going to say it's actually quite an interesting experience, because periodically I will ask my patient to show me how they put the drop in, and it's quite interesting how many of them use the drop. And I think the fault is on us for not really showing our patients how to use medications, especially the early glaucoma people we elect to treat with medication. We should be spending an extra 5 minutes with them to actually physically show them how to open the bottle and how to apply the medication. We just sort of say, here, these are some eye drops to use. I'll see you in a few weeks to see how they're working. And I think that is just the downfall of us being very busy. Perhaps we should be training our technicians to spend a little bit of time after we've seen the patient to go over that. But I think it's a very important thing that we should be doing.
I just want to add, we did a study with one of my residents who was a trained ophthalmologist from Egypt, but he came over to get his credentials in Canada. Simple study where I prescribed the medication for the first time, and then the patient went with him in the other room and with an artificial tear showed how they would use the drop. And some of the patients were actually putting the drop under their tongue because, again, through language barriers and just huff and the fuff, they didn't realize that the medication was for their eye. They knew it was for their eye, but they thought they put it in their mouth. So patients, when they aren't given the full instruction, we're leaving it up to them to decide how to use the drop, and not every patient certainly knows intuitively how to do it. So I couldn't agree more with what everybody said, is we have to almost take the time ourselves or our staff to guide patients when they're new users of eye drops.
Well, thank you very much, everybody. We could stay and talk for a long time further. I have no doubt about it. I think at this point I'm going to hand over to Jim and ask him to thank Dr. Hutnik and team. And again, many thanks, Katie, many thanks, Raj, and many thanks, Cindy and your team. It really has been great fun. Bye for now. Jim?